Hi guys, today we'll be discussing about heart failure, covering questions 17 and 18 from General Pathology, which talk about right side heart failure versus left side heart failure and the cardiac findings in heart failure. Uh, Both of them have been combined in this one video, and this is an extensive question. Like both of them independently are quite extensive, important questions stressed upon by many professors for the exam. And this video is going to be covering the general overview and basics that you must know for the exam. However, if you want to know more about each different etiology or pathology individually, you can check out the cardiology playlist on the channel. So moving on, starting off with the definition of heart failure. So heart failure is defined as the failure of the ventricles to pump blood adequately, and it could be either the right ventricle or the left ventricle that could be failing, or both. So it's as I said, it's divided into left side and right side heart failure with many different etiologies and pathophysiological mechanisms. And the clinical and pathological findings are very important and depend on the side of the heart affected. So apart from having right side and left side heart failure, you can divide it further functionally into either systolic or diastolic dysfunction of the ventricles. So when you have a systolic dysfunction, it basically you have a decrease in the cardiac output because of a lower ejection fraction. Uh, and it's mainly due to ventricular dysfunction. So when you have impairment in the contraction of the ventricles, and usually the ejection fraction is about 55 to 60% at rest. And if you guys remember, the formula for ejection fraction is the end diastolic volume minus the end systolic volume all over the end diastolic volume. And usually, basically, what happens is the ejection fraction falls below 50%, around 40, and could be even lower. And you can see like severe uh, clinical manifestations when you have a single digit ejection fraction, like, less than 10. That could be seen in dilated cardiomyopathy. And it's very important because uh, if the heart is not able to maintain an adequate cardiac output, the peripheral organs would not be perfused properly, and with lack of proper perfusion, especially the brain, you can either become comatose or even die. Then you have diastolic dysfunction. This refers to decreased cardiac output again due to defective ventricular relaxation, which impairs the filling and lowers the end diastolic volume, and which then causes a decreased cardiac output. So diastolic is basically a problem with the relaxation of the ventricles. So if they're not relaxing properly, they can't be filled properly. And if they're not filled properly, you will obviously have a lower volume of blood, uh, and a lower volume of blood basically would lead to decreased cardiac output because you will not be able to produce the same stroke volume with that, even if you have the same ejection fraction with lower volume of blood. And it can be further divided into heart failure with preserved and or reduced ejection fraction. So heart failure with preserved ejection fraction, it basically means that you still have a normal ejection fraction in this 55 to 60% range, but your heart is still failing. And in reduced ejection fraction, as you would see generally in systolic dysfunction, you have a lower ejection fraction than normal. So generally, this is not true for all cases, but in generally systolic dysfunction is heart failure with reduced ejection fraction. Meanwhile, diastolic is heart failure with preserved ejection fraction. So moving on, let's get into left side heart failure. So left side heart failure is failure of the left ventricle to pump blood to systemic circulation because of a decreased cardiac output. And cardiac output would be denoted as the capital letter Q. And it has multiple etiologies. So the etiologies range from ischemic heart disease, and within ischemic heart disease, you have coronary heart disease and myocardial infarction. You have systemic hypertension, uh, basically, which increases the afterload, leading to left ventricular hypertrophy. Left ventricular hypertrophy can also, again, you can have ischemic heart disease over there, and ischemic heart disease obviously leads to myocardial infarction. We'll be discussing more about this in the following slides. You can also have valvular diseases. For the left heart, you can have obviously need to have disease in the left-sided valves, which include the aortic valve and the mitral valve. Cardiomyopathies, the three main ones we have are hypertrophic, dilated, and restrictive cardiomyopathy, amyloidosis. Again, in amyloidosis, you also have senile cardiac amyloidosis, which is a deposition of non-mutated serum transthyretin, and you have also cardiac tamponade. Now, left side heart failure, going on to the pathogenesis in terms of ischemic heart disease. Now, ischemic heart disease is basically a group of diseases in which you have uh, transient to prolonged ischemia to the myocardium. And generally, you would see patients who do suffer from ischemic heart disease. More than 90% of them also have coronary artery disease, and they have atherosclerotic plaques occluding the coronary vessels. So when you have an occlusion of the coronary vessel, you have decreased perfusion to the myocardium. With decreased perfusion to the myocardium, you see that the oxygen delivery is not substantial enough to withstand normal contractile function. With that, the myocardium does not receive any oxygen, and uh, it still pumps at the normal rate. In some cases, even increasing the heart rate to try and get more blood and in turn more oxygen, which can lead to ischemia. Prolonged ischemia leads to necrosis or infarction. Uh, and that's how you get myocardial infarction from ischemic heart disease. Manifestations of coronary ischemic heart disease is basically an angina, which is chest pain. You can have three main types of angina. You have stable angina, which is basically chest pain only when you are having increased physical demand, or chest pain in relation to increased heart activity, which is basically when you exercise, or and then you have unstable angina, which is even at rest, heart like chest pain even at rest, and this manifests on ECG as NSTEMI, which is basically no or non-ST elevated myocardial infarction. And then you also have Prinzmetal angina, which is basically vasospastic angina. Basically, there's vasospasms of the coronary arteries, which occlude blood flow or decrease blood flow transiently. So you can have Prinzmetal angina. Myocardial infarction is a byproduct of coronary artery disease and can weaken the ventricular wall, decreases myocardial contractility, and can lead to heart failure with reduced ejection fraction. The MIs can be subendocardially or transmurally. Subendocardially basically refers to only a small portion of the myocardial wall being infarcted, and this results in an NSTEMI. Or it could be transmural. Transmural basically covers the entire thickness of the wall, of the ventricular wall. And if the entire wall is infarcted on ECG, the characteristic finding is ST elevation. As you can see over here on the right side, this is a normal ECG. This is ST elevation. This would be indicative of myocardial infarction uh, with transmural infarction. Basically, it's the entire ventricular wall thickness that has been infarcted, and that's why the exact reasons to why it is elevation and not depression or no elevation is because there are multiple different ECG vectors involved, but that's not important for the exam. And you have over here two types of NSTEMI. One is basically ST depression, where the ST segment becomes depressed instead of it being isoelectric, or you have T inversion, which is a later finding of STEMI, or could be basically uh, one of the things that happens because of unstable angina or subendocardial myocardial infarction. So the best way to test for uh, myocardial infarction in the lab is obviously ECG. ECG would either show ST elevation or ST depression. Then to confirm, you can also do blood tests for cardiac troponin I, which is cardiac specific troponin, and CKMB, which is sort of also myocardium specific. So both of these should be elevated for it to be confirmed as a myocardial infarction. And general clinical presentation of a patient would be sharp chest pain relating to the left arm, dyspnea, etc. So apart from that, the occlusion of the coronary vessels can be either because of the atherosclerotic plaque itself. So what happens is basically when you have an atherosclerotic plaque, uh, the plaque can undergo acute plaque changes, as it's called, in which what happens is a part of the plaque can embolize from its original site, go downstream, and occlude as the vessel gets narrower. So that's basically emboli arising from the plaque, or you could have thromboemboli occluding the coronary vessels by two different mechanisms. So one could be either because of the person having deep venous thrombosis with ASD, uh, Eisenmenger syndrome, and all of these different conditions together. However, it's very rare for this to happen, but could happen, in which the clot crosses from the right heart to the left heart, manages to enter the coronary circulation, and then produces a block. However, it's very, very rare. A more common way of thromboemboli, including the coronary vessel, uh, would be from uh, vegetations in valvular diseases. So basically, if you have valvular diseases with vegetations on it, so basically vegetations are any mass that could be found on the valve surface. So it could be sterile, non-sterile vegetations. So what they do is they can embolize from there and enter the coronary circulation and occlude smaller vessels. Uh, Instead of the larger main branches, it could go on occlude smaller vessels, so giving rise to small focal myocardial infarctions. And this is termed as paradoxical emboli, which paradoxical emboli is basically causing occlusion in the arterial system, because generally emboli arise from the venous system and go and occlude most commonly in the pulmonary circulation, in the pulmonary artery. Apart from that, you have reperfusion injury post myocardial infarction. The infarcted area is resupplied by blood once the occlusion is dealt with, whether if it's in a thrombus, it would be could be lysed, or any other mechanisms by which the blood starts flowing back again. It can cause two things. It can cause contraction band necrosis and reperfusion injury. Contraction band necrosis is basically due to the influx of calcium into that infarcted area. This calcium can act and then basically cause contraction of these dead cardiomyocytes, leading to contraction band necrosis and then reperfusion injury. Basically, you have these different types of mediators which can be flushed into the circulation and cause injury elsewhere. Moving on to systemic hypertension. So in systemic hypertension, what happens is that it's first of all it's characterized as an increase in blood pressure in the systemic circulation above 140 by 90 millimeters of mercury. So increased blood pressure increases the afterload, And the afterload is basically the pressure against which the left ventricle has to pump. An increased pressure basically means it has to increase the effort or the work by the myocardium to pump against this pressure. And what happens is that as it tries to increase work as a compensatory mechanism, what happens is you have left ventricular hypertrophy. There are two types of hypertrophy. There's eccentric and then there is concentric. So what happens over here is basically concentric hypertrophy, where the cardiomyocytes undergo increase in size and proteins, the sarcomeres, and these sarcomeres get added in a parallel to one another, allowing for increased contractile strength. So it can increase the pressure within the ventricle to overcome the pressure in the aorta. So because of this left ventricular hypertrophy, what happens is that you have more demand. So if you have the same perfusion rate with more increased demand, you're obviously going to have a demand perfusion mismatch, which can lead to ischemia and then obviously myocardial infarction. And then myocardial infarction gives rise to areas of focal whitish akinetic regions in the myocardium. Since they're akinetic, they're unable to contract. And since you're unable to contract, you basically have parts of the myocardium which are non-functional. They cannot help towards the function of the myocardium, and overall, chronically, this could lead to a failing ventricle. So as you can see over here in the picture, this is the left ventricle, this is the right ventricle, and you can see how much it has hypertrophy over here as a due to increased afterload because of systemic hypertension. Moving on to valvular diseases. So the four main ones you have to know over here are aortic stenosis, aortic regurgitation, mitral stenosis, and mitral regurgitation. So once again, similar principle for aortic stenosis over here. Aortic stenosis is the failure of the valve to completely open during the systole. So the left ventricle would technically need to produce a greater pressure, greater force for it to uh, forcefully open the valve. So compensation for this again is concentric left ventricular hypertrophy, so it can produce greater force. And with the left ventricular hypertrophy, you have a perfusion demand mismatch, and then it could lead to myocardial infarction. Then you have aortic regurgitation. It's failure of the valve to completely close during the diastole. And since it's not completely closing, obviously you're going to have some blood uh, entering back from the aorta into the left ventricle. So initially, this increased blood volume. So in the acute sense, like in acutely for the first few weeks of this happening, what happens is that since you have more blood flowing into the ventricles, you give rise to the Frank-Starling mechanism. So increased blood flow increases the end diastolic volume and the end diastolic pressure. When you have an increased end diastolic volume, what happens is that you increase your stroke volume and your ejection fraction. So this basically increases ejection fraction initially, but chronically over time, this is damaging to the myocardium because with an increased end diastolic volume, you also have an increased end diastolic pressure. And when you have an increased end diastolic pressure, this forces a greater pressure difference between the subendocardial vessels um, and the farthest part of the myocardial wall for perfusion to occur properly. So if there's a greater difference between the vessels, there will not be adequate perfusion to the myocardium. And with decreased perfusion to the myocardium, chronically over time, what happens is you get eccentric left ventricular hypertrophy instead of concentric, in which sarcomeres get added in series instead of parallel. And you can also have um, left ventricular dilation to accommodate for this extra blood that comes in. Then you have is mitral stenosis. Mitral stenosis, again, failure of the valve to completely open during diastole. This causes, instead of affecting mainly the left ventricle, it affects mainly the left atrium, causing left atrial hypertrophy. So the atria can squeeze this and force this blood into the ventricles. Mitral stenosis can cause left side heart failure, but it is more so related to the right side heart because it can transfer, and we'll discuss how left side heart failure can transfer into right side heart failure in the following slides. Then you have mitral regurgitation. It's failure of the valve to completely close during systole. So you have backflow of blood into the left atrium. So when you have backflow into the left atrium, there's obviously going to be a reduced stroke volume and ejection fraction. And as a compensatory mechanism, you have, again, eccentric left ventricular hypertrophy with the same consequences as aortic regurgitation in the chronic sense. Then moving on to left side heart failure and cardiomyopathies. So just basically, we're only discuss the three main ones and not all five of them. So you have hypertrophic cardiomyopathy, which is extensive eccentric hypertrophy of the uh, sorry, should be concentric hypertrophy of the left ventricle and septum. With at least with diastolic dysfunction, because of this hypertrophy, what happens is that it prevents the myocardium from relaxing completely. And if it cannot relax completely, it doesn't fill properly. And lack of ventricular, physiological ventricular filling gives rise to is basically diastolic dysfunction and gives rise to complications such as certain cardiac death. This is seen in many athletes because of their hypertrophy in the myocardium, and then it also causes MVP, which is termed mitral valve prolapse. So what happens in mitral valve prolapse is that because of this extensive hypertrophy of the left ventricular and septum, it pulls the anterior leaflet of the mitral valve forward and upwards. Basically, in the if you can imagine the heart, what happens is that, let me just draw it out. So if this is the heart, this this is your septum over here. This is the left ventricle. What happens is that you get hypertrophy, extensive hypertrophy um, of these structures. So this structure becomes much larger. And this pulls the leaflets. So if I were to draw the leaflets in a different color, let's say black. So it will pull the leaflet upwards and medially towards the septum. So it comes into the left ventricular outflow tract. So basically, where the blood is supposed to be pumped from the left ventricle into the aorta through the aortic valve, it brings it towards this outflow tract. And this basically does two things. It firstly blocks the left ventricular outflow tract, so it reduces the amount of blood that actually flows from the ventricles into the aorta, and also forces regurgitation back into the left atrium. And this is so extensive that it can basically reduce the ejection fraction so much that in an acute setting, it could lead to certain cardiac death. And this is one of the most common uh, ways that you can see certain cardiac death in young athletes who are just working out or just in a match or playing, where they just suddenly collapse and die because of this severe amount of regurgitation and lack of an adequate cardiac output as their heart rate is increased. Then moving on, you also have restrictive cardiomyopathy, basically decreased compliance of the ventricular walls, diastolic dysfunction, and it leads to heart failure with preserved ejection fraction. What happens in this is because you have decreased compliance of the ventricular walls. Decreased compliance means that they're going to also be not relaxing completely properly. Uh, Again, poor filling, but they still are able to maintain a normal ejection fraction. But they also, because of impaired filling, they have a lower stroke volume. Lower stroke volume directly translates into a lower cardiac output. Then you have dilated cardiomyopathy. Dilated cardiomyopathy is the most common type of cardiomyopathy in which you get global dilation of all four heart chambers, leading to systolic dysfunction. So it is somewhat, in sense, the opposite of hypertrophic cardiomyopathy. You get basically thinning of the ventricles instead of, as in hypertrophic cardiomyopathy, you get thickening, or and in dilated you get thinning basically. So if they're thinner, they're weaker, the ventricular walls, and weaker ventricular walls lead to um, decreased cardiac output, decreased contractility of the myocardium, basically reduces ejection fraction, reduces cardiac output, and can lead to shock, can lead to loss of consciousness, many different complications. Apart from that, you can also have mitral and tricuspid regurgitation. So similar thing, since the ventricular walls are weaker, so are the connections with the valves. Weaker connections with the valves, they can affect the anatomy of the valves, pulling it closer or further, with that leads to basically these regurgitation valvular defects. Also arrhythmias, because of the changing in the changes in the myocardium. This can also affect the conduction pathways, giving rise to arrhythmias and thrombosis, because there's room for blood. More room for blood, basically, if the blood is at a standstill in any of the chambers for a long period of time, it can lead to promote clot formation. Moving on to amyloidosis. This is also another question in general pathology, so you should know from there. But in the heart, especially, you get something known as senile cardiac amyloidosis. There's also another version of this known as familial cardiac amyloidosis, in which instead of, as over here, you have non-mutated serum transthyretin, which is depositing in the myocardium. Again, leads to ventricular filling impairments and heart failure with preserved ejection fraction. In familial cardiac amyloidosis, it is deposition of mutated serum transthyretin, and that is a genetic condition. And serum transthyretin is the second most common protein in blood. And apart from that, you can also have primary amyloid light chain type of amyloidosis in the heart, and similar mechanism as senile cardiac amyloidosis. Impaired ventricular filling, and impaired ventricular filling leads to heart failure with preserved ejection fraction. Moving on to the complications of left-sided heart failure. Now, there are two main things you need to remember for this. And the first one is decreased systemic perfusion. If you have a failing left ventricle, which is not able to maintain an adequate cardiac output, this means you will also have a proportional reduction in perfusion to their organs, to the end organs. So, and most important over here, the organ is the kidneys. The brain is also an important organ, but uh, for that to happen, your cardiac output needs to decrease quite substantially for oxygen delivery to be very low. But the main thing is the kidneys. Why? Because it can worsen your heart failure. When you have a failing ventricle, you obviously do not want to make it work harder. Uh, but the kidneys do. How they do that is when you have decreased perfusion to the kidneys, this inadequate blood pressure activates the renin-angiotensin aldosterone system. The RAS system gets activated, and basically it causes constriction of the arterioles. So this increases the total peripheral resistance. And increasing the total peripheral resistance, so increases the blood pressure. And increased blood pressure means increased afterload for the heart, and increased afterload means that the failing ventricles have to work harder against this afterload. So it worsens the condition even more because your ventricles are already failing, and then an increased afterload is not what's required for them. But this is what happens, and the kidneys tend to make things worse for the heart. Next, we have pulmonary congestion. So, as the blood is not able to get pumped in the systemic circulation, the blood is gonna pool up in the circulation behind it, leading to pulmonary congestion. So you have pulling of pulling up of blood into the pulmonary circulation. This can lead to pulmonary edema. Pulmonary edema can lead to pulmonary hypertension, and pulmonary hypertension causes right side heart failure, and this is called cor pulmonale. And the major important microscopic finding over here is hemosiderin-laden macrophages. They're also called heart failure cells. And moving on to the morphological findings, microscopic and macroscopic findings. So extracardiac pathological findings in acute heart failure, you will see pulmonary congestion and pulmonary edema. In the chronic sense, you would see brown induration in lungs due to long-standing pulmonary edema. Basically, this happens because the macrophages, they come to clear all of this up, and they lyse the RBCs. And when the RBCs are lysed, the iron from the hemoglobin is taken up into these macrophages, turning them into this reddish brownish color. And that's why you get lungs on autopsy macroscopically that look brown, and that's called brown induration in pulmonary edema. Important intracardiac pathological findings include you see hypertrophic, so concentric versus eccentric. Concentric hypertrophy, basically, we discussed this earlier. You would see this in systemic hypertension, in anything in which you require the myocardium to work more. You want to increase contractility to overcome a pressure or overcome anything else. And you see eccentric hypertrophy when you have generally diastolic dysfunction. And then in acute and chronic changes, so acutely, there is not enough time for the heart to adapt. So the only thing that happens is dilation of the ventricles or the dilation of the heart chambers, mainly the ventricles. The failing ventricle will dilate. So this is very important. So acutely, no time for the heart to adapt. That's why you get dilation of the ventricles. Chronically, first, what happens is you get concentric. Concentric is generally the first change that happens. And when the heart cannot add any more cardiomyocytes in parallel, where it cannot do any more concentric hypertrophy, it then switches to eccentric hypertrophy. And eccentric hypertrophy is generally one of the end changes that occur in the heart. Uh, and then you can see the valvular defects. If there are any valvular defects, you can see the regurgitation, you can see damaged valves, prolapsed valves, stenotic valves, etc. And autopsy findings macroscopically. Myocardial infarctions on a heart basically look like small white hard akinetic fibrotic lesions, which can vary in size depending on the type of myocardial infarction, whether it was subendocardial or transmural, and the location where it occurred. And another thing you can see is right side heart failure if left side heart failure gets carried out to the uh, right side. Then moving on to right side heart failure. So defined as inadequate blood supply to the lungs due to increased pulmonary circulation pressure or pulmonary hypertension. It is reduction of blood volume pumped as well. So both. So mainly when you have a failing ventricle, you should think of the ventricles like this. The right ventricle should be thought as the volume pump because its main function is to get an adequate amount of blood volume into for oxygenation, and then the left ventricle should be thought as the pressure pump, where it should pump blood to high enough pressure to maintain uh, perfusion to the end organs. Uh, the three main etiologies that you have for right-sided heart failure is left-sided heart failure and everything we just discussed earlier. So, and we'll discuss how each of them can transfer into right-sided heart failure, and it's also the most common cause, left-sided heart failure. Uh, and then you have lung diseases, acute and chronic lung diseases can contribute to right-sided heart failure. Then you have left to right shunts. These are congenital defects which can give rise to right-sided heart failure, and we'll discuss them in the following slides. So, how does left-sided heart failure develop into right-sided heart failure? This is an important question, and the mechanism is also important. This can be uh, asked in almost all the attempts which get this question. So, general pathophysiological mechanism converting left-sided heart failure into right-sided heart failure is as follows. So, what happens in left-sided heart failure is you have decreased cardiac output. This leads to backup of blood, causing pulmonary congestion. Long-standing pulmonary congestion leads to pulmonary edema, and pulmonary edema increases the pulmonary circulation pressure. If you have an increased pulmonary circulation pressure, it would lead to pulmonary hypertension, and healing of these pulmonary lesions of edema is going to be by fibrosis because these macrophages are going to come and promote healing after clearing everything up. Pulmonary hypertension increases the pressure against which the right ventricle has to pump to maintain an adequate blood supply into the lungs. So you get right ventricular hypertrophy as a compensatory mechanism to overcome this pressure. Then what happens is that the right ventricle hypertrophies enough, and then you get a perfusion demand mismatch. So there is more demand for oxygen and the nutrients. However, the supply is the same or less if there is any underlying condition such as atherosclerosis or coronary artery disease. And then that could develop into myocardial infarction. And then you get parts of the right ventricle which are akinetic and not working out as supposed to. And it's referred to as cor pulmonale. Basically, right-sided heart failure due to pulmonary hypertension. The term is cor pulmonale. Do remember. Then moving on to right-sided heart failure because of lung diseases. See, underlying mechanism by which right-sided heart failure occurs is essentially due to pulmonary hypertension. So pulmonary hypertension is the main thing you need to know about right-sided heart failure because that's the main thing what's going to cause the right ventricular hypertrophy and the oxygen, the perfusion demand mismatch, and then the myocardial infarction. But the etiology of how the hypertension develops can differ. In acute disorders, you can get embolism. So pulmonary embolism, what happens is blocking of the arteriole or arterioles if there are multiple thromboemboli. As a physiological response, what happens is it leads to vasoconstriction of the blood vessels. Vasoconstriction increases increases resistance, and increased resistance increases blood pressure. So what happens is that it leads to pulmonary hypertension. And again, pulmonary hypertension increases the uh, the cardiac work of the right ventricle to overcome this pressure. And again, as mentioned earlier, can lead to a failing right ventricle. Inflammation of lungs, such as acute respiratory distress syndrome, pneumonia, basically hypoxia, and then the response to hypoxia is also vasoconstriction. Vasoconstriction leads to hypertension, and hypertension leads to right-sided heart failure. Restrictive lung diseases can lead to pulmonary fibrosis. When you have pulmonary fibrosis, it will also uh, the lung will lose its elasticity, then which will cause an increased resistance in the vessels, leading to pulmonary hypertension, and they include things such as idiopathic pulmonary fibrosis, silicosis, asbestosis, and all the other different types of obstructive lung diseases. Emphysema and obstructive lung disease, what happens is destruction of the terminal alveolar walls. Rupture of these weakened air spaces create larger air pockets. So when you have larger air pockets, what happens is the vasoconstriction as a physiological response, and then hypertension, and then obviously developing chronically into right side heart failure. Left to right shunt. So these are a group of congenital heart diseases that allow the flow from the left heart to the right heart through a defect in between the chambers. So they can include ASDs, which are atrial septal defects, VSDs, um, ventricular septal defects, and PDA, which is patent ductus arteriosus. So what happens in this is basically when you have a left to right shunt, as the name implies, you shunt from the left heart to the right heart through these. Since the pressure on the in the left heart is greater than the pressure the right heart, blood generally flows from the left side to the right side. Flowing of blood, so through the ASD, if it flows through the ASD, the atrial septal defect, it increases the pulmonary right ventricle uh, and pulmonary right ventricular volume and pressures. So what happens if you increase pressures and volumes in the right side of the heart, force the heart to undergo hypertrophy to be able to withstand these higher pressures because of the excess blood that is being forced into the right heart. As the right ventricle hypertrophies, at a certain point, what happens is that the right ventricle hypertrophies greater than the left ventricle. And this can cause shunt reversal, and that's termed as Eisenmenger syndrome. When the right ventricle hypertrophies beyond the left ventricle, and a left to right shunt becomes a right to left shunt because of there being an increased pressure generated in the right ventricle, which forces blood into the left side of the heart. So what happens is that this is how one-way right ventricular hypertrophy can occur, and which can then lead to myocardial infarction and failure of the right ventricle. And due to the increased pulmonary flows and pressure, this can also increase the pressure in the pulmonary circulation. And increased volumes and pressure in the pulmonary circulation can lead to hypertension, and then hypertension, obviously, pulmonary hypertension leads to right side heart failure. Finally, we get to the uh, cardiac findings in right side heart failure. So intracardiac finding, you get eccentric right ventricular hypertrophy chronically. And if in the acute sense, if you have uh, a rapid onset of pulmonary hypertension, uh, no matter what the cause is, uh, if the heart does not have enough time to adapt, the only thing the heart can do is dilate, and you get right ventricular dilation acutely. Extracardiac findings, there are many. So what happens is that you get jugular vein distension. So since the blood is going to be then backed up into the systemic venous systemic circulation, because the right ventricle is not able to pump this blood, so you get distension of the uh, jugular veins. Uh, the right atrium uh, is unable to pump blood into the failing ventricle, or the failing ventricle is not actually able to get this blood into the lungs as it's supposed to. Then you get hepatosplenomegaly. Now, hepatosplenomegaly occurs as follows: because there is systemic venous congestion behind the right ventricle. So basically, every major veins in the human body that drain into the right atrium and then eventually into the right ventricle, they're going to be congested to a degree. And one of the major veins is the hepatic vein, which drains into the inferior vena cava, and the inferior vena cava then comes into the right atrium. So when you have blocking over there, this excessive blood pressure and blocking in the inferior vena cava and the hepatic vein gives rise to hepatic portal hypertension. There are three types of portal hypertensions. So this is post-hepatic portal hypertension. Uh, so two things happen in the post-hepatic portal hypertension. Firstly, you get uh, shunting to the spleen because of the different shunts that occur. So you get splenomegaly because of increased blood volume in the spleen. And next, because of this standing blood and hepatosplenomegaly, if the liver gets damaged and cirrhotic, you see a nutmeg liver. This is another characteristic finding. An important finding is nutmeg liver in right-sided heart failure. And then you can see lower extremity edema, which is bilateral and pitting, and you see cyanosis. These are the main things you can see. Apart from that, nothing else. These are the main ones. I know this was a long video and covered a lot of things in a lot of detail, but it's an important question for the exam, and you should know like the main basics about all of the questions in cardiac pathology. So if you study your cardiac pathology well, you'd be easily able to answer this question in the exam. Thank you.